Okay, let's get started, everyone. Good evening, good afternoon, good morning, depending upon what part of the country or the world you are watching from. I'm Harry Hoyen, and I'm welcoming to the third part in the Hand Essentials surgery series. This is on basic nerve physiology, common compressive neuropathies, and I'll introduce my faculty as we go. Sanu, next slide, please. Sanu Jain from the University, Ohio State University, will be our speaker this evening. I'll be moderating, as well as Paul Benhammer from the University of Toronto. We have Peter Ree to help answer questions, and Becky is from Elon University, and we're really going to talk about some rehabilitative and strategies involved in nerve regeneration. Next slide. These are our disclosures from each one of us. They have been resolved and adjudicated for the talk. There are no relevant conflicts for this particular talk. I'm going to kick it off today by asking everyone to mute your microphones, turn your videos off if you can. There is a Q&A portion at the bottom. Please ask Q&A questions throughout. We will have Peter Ree, Paul Benhammer, and myself answering some of the questions by typing them, and I'll query some for discussion at the end of the talk. Go ahead, next slide. Basic learning objectives today, and this is a really fascinating topic to all of us, is elucidating some of the physiology of nerve injury and compression. Explain the time course of nerve regeneration, what happens, and then Sanu's going to detail some of the indications and the techniques for surgical intervention. Go ahead. Let's start with a case to sort of prime us for today, and this is a 64-year-old female, 1 year after distal radius fracture. She has complaints of not so much pain, but persistent numbness and weakness. I'll say weakness in the median nerve distribution, and that's the thenar muscles, but really persistent, dense numbness. Her procedures were done, open reduction tone fixation, distal radius, and carpal tunnel release at the same time due to some median nerve deficits at the surgery. This is her final sort of follow-up radiographs. I did not do the procedure, but she was sent for consultation. They appear appropriate, and we can discuss these at the end. Next slide. These are her nerve conduction studies that she came with, and as you can see in the yellow, and Sanu is really going to detail these, is the latencies of the motor and sensory components. In the blue or purple is the amplitude. On the right are the needle portion of the electromyography part and the sensory. Go ahead, next slide. And very much detailed by this particular electromyographer was the response specifically to the index, middle, and ring, and how it was different as compared to the contralateral side. So quite a comprehensive study. So her questions, go ahead, next slide, were, to me, why do I still have numbness and weakness even though I had a carpal tunnel release? Very interesting. Will another procedure help? And then also, will another procedure make my condition worse? So I want you to think about these three questions. We'll come back to this at the end. And I'm now going to hand it over because Dr. Jane's going to go over some of these topics in great detail and help us understand this. All right, kick it off.
Great. Thanks, Harry. So this is a really interesting topic, nerve physiology injury, and what to do about it is actually a pretty exciting topic in hand and upper extremity surgery. So I'm going to kind of go over the basics first with nerve anatomy. I'm not going to dwell on this. Just know that axons are nerve fibers that are encased by endoneurium. Schwann cells surround the individual myelinated axons, and the fascicles, they're groups of axons, and they're surrounded by perineurium. And the epineurium is what surrounds the outer sheath of the peripheral nerve itself. So pathophysiologically, what happens to the nerve? So Wallerian degeneration, you hear that term, it's degeneration distal to axonotomesis, where you have injury to the axon, and you have this neurotropism, which is this chemotactic gradient toward the distal nerve stump, which helps attract that nerve to the distal stump to enable it to heal. And also the neurotropism, which is a nutritional support that's provided to those axons when they connect to that distal stump. So that previous slide is more relevant to actual traumatic nerve injury. When we're looking at pathophysiology of nerve compression, it goes down this pathway of this blood-nerve barrier breakdown, and which leads to connective tissue thickening and demyelination, and eventually axonal degeneration. So it's a little different process, but it does end up with neuropathy and axonal degeneration like it shows. So what you want to know is that the size of the nerve and the space through which it passes is really important. So compression alters the neural microvasculature and the blood flow dynamics, and that causes ischemia and edema, as you're probably well aware. And those mechanical forces stimulate Schwann cells proliferation and apoptosis. So the consequences of these are inflammation, fibrosis, demyelination, and eventually axonal death, which occur late. So what you want to take away from this is that the axonal injury is proportional to the time and extent of compression. So the way the nerve recovers is that it heals at about 1 millimeter a day, or approximately 1 inch a month, and the motor end plate loss occurs about 1% a month, and you about 25% of it for functional muscle contraction. Best reinnervation occurs within 3 months, and functional reinnervation can occur up to about 1 year, but no reinnervation occurs after about 2 or 3 years. So this is a classic nerve injury classification table, initially by Seddon and then by Sunderland, and then we have the grade 4 by Dr. McKinnon and Dellon, which lists the different grades of nerve injury. And what you want to take away from this is that your grade 1 is your neuropraxia, your grades 2 through 4 are your axonotomesis, and your neurotomesis, which is a complete nerve transection, is your grade 5. So when you have a grade 4 or a grade 5 injury, what you want to understand is those are not recoverable injuries. Those are nerves that are going to probably have to be reconstructed, as opposed to the grade 1, 2, and 3, which can probably be observed and be taken care of with decompression. This is a similar slide, just showing it more in a cartoon type fashion, so it's more visually appealing. So you can see the actual injury here with the neurotemesis and the axonotomesis in the nerves themselves. So what you want to do is obtain a history, physical examination, obtain clinical studies, which include your nerve conduction study, your EMG, and you may get imaging such as ultrasound or an MRI for this. So carpal tunnel syndrome occurs much more often than cubital tunnel syndrome, which occurs much more often than radial neuropathies or ulnar tunnel syndrome or pronator syndrome. And so you can see here just the different areas where these different neuropathies occur. So physical examination, you want to have a sensory evaluation and nerve-specific motor examination. So check the nerves bilaterally, check both hands, use two-point discrimination to check the innervation density. You can use Sims-Weinstein monofilament testing as well to get threshold sensitivity, and that's pretty sensitive. And then you could do the 10-10 test decided by Dr. Strauss, which basically if you have a normal side, that's a 10, and you sort of touch the abnormal side and have the patient tell you, is this on a scale of 1 to 10, what percent of that, or not percent, but on a scale of 1 to 10, what would that be compared to the other side? It would be a 5 out of 10 compared to 10 out of 10 on the normal side, etc. So electrodiagnostic testing, you want to look at your nerve conduction studies, which will show you your segmental demyelination, show any slowed nerve conduction or any block. And then your EMG is going to really show you more of your axonal loss and any muscle denervation. So the nerve conduction studies are pretty sensitive and specific, as you can see, even though there's a range noted here. So, every lab has their own set of values, and, you want to adjust that to the patient's age and to the temperature of the patient and the temperature of the room. So you want to compare it to the other side to get the best comparison as well. So, so when you look at the nerve conduction studies, you want to look at the compound muscle action potential CMAPs, which is the recorded motor response of the muscle fibers. Each of those muscle fibers action potential generates multiple, muscle fiber action potentials. And so you also have for the sensory portion as well, and that localizes the injury, and it's more sensitive, and it's abnormal. You'll get the abnormality before the motor conduction shows that. But again, the other thing you want to realize is, again, the norms that you have, you want to look at each lab. Every EMG has a different norm. So there's not, even though we're going to talk about some normal values, it may change a little bit here and there depending upon the lab, and on the equipment and the diagnostician. So conduction velocity, that reflects the speed of the action potential propagation along the fastest conducting nerve fibers in the nerve study. So it's looking at the fastest nerve fibers. So even if you have some slow ones on there, it's not going to pick that up. So it's just going to get the fastest one. So it's going to look at those fast myelinated fibers. So your EMG is going to evaluate the integrity of the motor unit, the activity of the muscle fibers, and you have 3 phases which are really important here. And that's the insertional phase where you put the needle in, the rest phase, which is after that, and the activation where you have volitional control. And that will show you if there's any axonal degeneration. So the insertional phase. So how does the muscle react when the needle is inserted? So you get an abnormal value for that in terms of being decreased when there's fat or atrophy present, and it's increased when there's a little bit more of a normal variant. Then you have how the muscle reacts when the needle inserts here. So this is the graph that kind of shows you that in this ulnar nerve here, the first dorsal nerve osseous shows an increased insertional phase. And then the rest phase, that will show you the motor axon loss, and you get the fibrillations. And that is spontaneous, and they can appear about 3 weeks from injury. And you cannot control this. It's not volitional. So you can see here on the EMG here, you're seeing the fibrillations and sharp waves right here in the spontaneous activity. And then you have the activation phase. You're going to find this in the volitional motor unit action potential section of your EMG, which is right here. And that's going to evaluate the integrity of the motor unit. And that you do control. And you're going to look for recruitment and the firing pattern morphology for that. And that gives you an idea of the status of that muscle. So other ways you can test and look at the nerves are MRI or MR neurography. It's a secondary tool. You might be able to find space-occupying lesions, map out a denervated muscle, and find any anatomical variants. Ultrasound is also another useful tool that's starting to take hold more so. You can, again, find space-occupying lesions. You can help guide steroid injections, and you can also identify median nerve and ulnar nerve cross-sectional areas, and it can be more sensitive than MRI and has equal specificity. So I'm going to go to the compression neuropathies, looking at the median, ulnar, and radial nerve aspects of this. So we look at the median nerve, we're thinking carpal tunnel, we're looking at pronator syndrome, looking at anterior osseous syndrome. And so carpal tunnel is the most commonly reported nerve compression syndrome. You get numbness in the volar, thumb, index, middle, and radial ring finger. You can see this cross-sectional area right here of the carpal tunnel with the median nerve, the flexor tendons. So you want to obtain a good history. Nocturnal paresthesias with wrist flexion activities, volar wrist pain. You can drop things, and a lot of times people will complain of decreased grip strength. So on exam, you'll see thenar atrophy, sensory testing abnormalities, and poor thenar strength of the ATB muscle, and pinch. So provocative tests that you can do for this include the Tinel sign, which has a reasonable specificity and sensitivity, and Phalange's also a little bit better, slightly, but your median nerve, which is your Durkin's test, is much more sensitive and specific. You want to do this for about 30 seconds, and I usually combine the median with the Phalange's and get a modified or an augmented Durkin's for that to do that in one step, again for 30 seconds. So looking at nerve conduction studies, you're going to get increased latency, which is slowing. So you're looking at the time it takes for that nerve conduction to travel. So that tells you there's demyelination. And so when that's greater than 3.4 milliseconds for sensory and greater than 4.5 for motor, then you're looking at abnormalities there. And also when you're looking at the conduction velocity, when you have a decrease which is less than 52, again, these will vary depending upon where you get your EMG. So this may be 50 in a different EMG, but this is a rough idea of what we're looking at when you have a decrease. But if it's less than 52 plus or minus, then you're looking at an abnormality there. And that's, again, fairly sensitive and specific. So again, you can see here your latencies increased here for your sensory portion. Again, greater than 3.2 in this EMG, and you can see that right there. And then also your EMG portion here, showing you changes as well with fibrillations and sharp waves here. So for carpal tunnel syndrome, there are different methods to treat it. Obviously, non-operative management is best first. And so we look at rest, splinting, non-steroidal anti-inflammatories, and potentially steroid injections. And then you have your operative treatment, which could include an open, mini-open variation, or an endoscopic approach to that. So, you know, there are theoretical advantages to an endoscopic versus open. Here, looking at the open carpal tunnel release, you have better direct visualization of the median nerve and of the carpal tunnel, and, you know, potential disadvantage, you may have a little bit longer recovery. You can see here, just this is kind of a little mini-open approach, just opening the carpal tunnel, just getting a general idea of how that's done. And then an endoscopic, you may theoretically have a shorter recovery, but you may also have a theoretical disadvantage of not visualizing the carpal tunnel as well, and might have a higher learning curve. As you can see here, this is going from the undersurface of the transverse carpal ligament and dividing it from distal to proximal using a proximally based port to release that transverse ligament. So, you know, case one, we have a 49-year-old male with a year history of numbness and tingling in bilateral hands, no, you know, significant past medical history. And let's see, you can see as these symptoms of tingling, numbness, cramping. And on exam, no thenar atrophy, but a little bit decreased pinch and grip, and 2 points, not too bad. But when you look at the nerve conduction studies here, you can see increased latencies based on the norms that we talked about earlier. And you can see here motors greater than 4.3 or 4.5, and this is greater than 3.4 here. And that indicates there is some compression of that median nerve. And so this person would probably benefit from a carpal tunnel release. So there are other median neuropathies in the forum as well, and they include the aneurysmus nerve syndrome as well as the pronator syndrome, and they have common sites of compression, including the lacertus fascia, the pronator teres, and the fibrous arch of the flexor digitorum superficialis. So the anterior AIN palsy is pretty rare. It's about 1% of compression neuropathies. It can be common with the viral neuritis or Parsonage-Turner. The nerve divides about 6 centimeters from the AC fossa, and you primarily get a motor deficit of the FPL and the FDP of the index finger, and you'll get an abnormal EMG. So it's a motor palsy, again, related to transient neuritis. And so, again, we're talking about the branches radial and deep to the FDS, and you get this vague forearm pain. And you can see here, this is a nice picture showing you in the right hand that you have this lack of this O sign, can't flex that DIP joint of the index and the IP joint of the thumb. So management largely non-operative. Most of these spontaneously resolve within about 12 months. But obviously, if they persist beyond that, you could explore this and release the points of compression, including lacertus, fibrosis, the ulnar head of the pronator teres, the proximal fascial margin of the FDS arch, and then there's this Ganser muscle, which is this anomalous origin of the FPL muscle. So, and then we have pronator syndrome, which is pain in the proximal forearm. You get weakness, paresthesias in the palm, median palmar cutaneous nerve. You actually get a normal EMG here, and 1% of the population has this supracondylar process right here, which can be a sign that this may be a problem that this patient may have. So what you can see here is different sites of compression, including this ligament of Struthers, this bicipital aponeurosis, which is a lacertus I mentioned, pronator teres, and this tendinous arch of the FDS. The most common sites are first the pronator teres, and the second is the tendinous arch of the FDS right here. So on exam, you can get a positive Tinel sign right here at the proximal forearm, and you can get pain with resisted elbow flexion with forearm supination. And then you can also get it with resisted contracture of your FDS muscle right here as well. And if you also flex the elbow and try to supinate that as well. So management is largely non-operative, it's conservative, splinting NSAIDs, activity modification, and then obviously you can release the points of compression if you're looking at operative management for this. So why are the EMGs normal in this case? Well, there's enough pressure to affect these C fibers, which is these small, unmyelinated fibers, but not enough pressure to affect the large myelinated fibers. This is why you don't see it on the nerve test. So we're going to move to the ulnar nerve. So we look at the cubital tunnel and ulnar tunnel syndromes for this. So these are sites of compression of the ulnar nerve. Cubital tunnel, you have the arcade of Struthers proximally here, and you have your intermuscular septum, your fascia of the cubital tunnel, you have your Osborne's band in continuity with your FCU fascia, and you have this deep submuscular fascia deep to the FCU. In the ulnar tunnel, you have your antebrachial fascia, your fascia over the ulnar tunnel, and then you can get this deep hypothenar fascia leading edge of your motor branch going deep. So cubital tunnel is the second most common compression neuropathy, involves the ulnar nerve at the elbow, and the size of the cubital tunnel changes with elbow flexion, and that can cause intraneural pressure, not only a compressive force, but also a stretch force, which could cause some of the damage that we see with this neuropathy. So on exam, you'll see potentially intrinsic wasting. As you can see right here, first dorsal interosseous muscle wasting, clawing of the fingers here, Fremont sign, which is, using your IP joint, your FPL muscle to compensate for your weak adductor, difficulty crossing your fingers, positive elbow flexion test, you get a compression test at the elbow, you get Tinel's at the elbow, decreased sensation in the ulnar nerve distribution, and then the scratch collapse test as well. So you can see here the distribution, sensory distribution of the ulnar nerve in the hand, the palmar cutaneous, as well as the dorsocutaneous of the ulnar nerve. So on the nerve conduction studies and EMG for cubital tunnel syndrome, you'll see decreased conduction velocity across the elbow. So we say about less than 50 for that. And then you can also get prolonged latencies, again, across the elbow, greater than 3.5 for motor and greater than 3.1 for sensory. And you'll get the normal latency in the distal part of the forearm. So you can see here, increased latencies, decreased amplitude, decreased conduction, increased latencies, decreased amplitude, and decreased conduction velocity across that nerve. Again, you can see EMG findings as well. So similar to the other syndromes, you want to try non-operative management first, including various modalities. And I'll break here for a moment and have a little thoughts about where occupational therapy and splinting fits in for clawing and for chronic ulnar neuropathy at the elbow. So,
Becky, go ahead.
Yeah, absolutely. So, when we're thinking about chronic neuropathy at the elbow and we're thinking about a loss of ulnar nerve innervated musculature in the hand, your therapist can help you in many ways and also help your patients to be incredibly functional during the compensatory phase. It's a very quick and easy little splint to make that goes on the ulnar side of the hand, brings those MPs down into flexion, which allows the extensor mechanism to translate forces towards extension. So your patient has the ability to flex and extend and maintains the closed pack position of the MP joint. So you're really saving your joints and you're saving yourself a lot of trouble on the back end of this. Patient's very functional, very easy splint to wear and to make. I would also say probably one of the most important things when I work with patients that have chronic cubital tunnel and ulnar nerve issues in the hand is the sensation. And so the hard part is when you've lost sensation on the ulnar aspect of your hand, that side of your hand is the furthest away from your visual field. So it's very easy for patients to burn themselves. And we know that if someone has completely lost their protective sensation, that they're more likely to actually smell their hand burning than they are to feel it burning. And I often tell my patients that as an example to scare them a little bit, that they really want to use their senses, their vision, and their other senses. Hearing, do you hear anything off? So make sure you're looking and hearing and listening to make sure you're not going to put yourself at risk of burning or injuring your hand further because of that loss of sensation.
Great, thanks. It's amazing how many patients will present on their initial evaluation with atrophy already in the ulnar motor distribution, and they haven't noticed that their MP joints are extended, or they have issues. They just, they have some clumsiness. Versus sometimes in carpal tunnel, the first presentation is these sensory deficits. So even if they come in with some numb fingers, really pay attention to the compensatory things that can be done for the patient, and they'll be very important afterwards because the regeneration takes so long. All right, go ahead, continue. Thanks.
Good. Thanks. So, and then there's the operative management as well. So obviously, if they fail conservative management and they have advanced neuropathy. So we talk about a couple of options here, or actually kind of three options. One's the in situ, and then transposition, and you have your subcutaneous versus submuscular or transmuscular approach. Medial epicondylectomy is not done fairly frequently for this. There's different schools of thoughts on what's best for patients for this. But you can see here, this is just an elbow being flexed, showing an in situ release and no subluxation of that ulnar nerve. So in situ decompression, you can see the ulnar nerve is here in the medial epicondylar groove, and this retractor right here is showing a branch of the medial antebrachial cutaneous nerve that you want to preserve when you're doing these surgeries. So you can see that going to the skin there. And then this is your submuscular transposition. You want to take down your intramuscular septum completely. And then you do a flexor pronator Z lengthening, and you have to also release the fascia distally, so there's no compression as it makes a turn from your sling distally into the flexor carpi ulnaris. And then you also want to check particularly for this case, is make sure that your nerve is not kinked or having any compression with elbow flexion or extension. So then there's ulnar tunnel syndrome, which is your median nerve compression in Guillon's canal at the wrist. And so there's three different zones of the ulnar nerve. Zone 1, which has both the motor and the sensory portion, a mixed portion. You have zone 2, which is your motor primarily, and zone 3, which is sensory. And so you'll get this altered sensation and weakness in zone 1, and only muscle weakness in zone 2, and just altered sensation in zone 3 makes sense because that's the type of nerve that's there. And so you want to know that Guillen's tunnels from this pisiform to the hook of the hamate. So things you want to look for when you have compression of the ulnar nerves, also look for potential ganglions. Is there a hamate fracture? And interesting to note is one way you can clinically differentiate this from cubital tunnel is that your dorsal cutaneous branch of the ulnar nerve sensory portion is usually intact, because that comes off the ulnar nerve proximal to the wrist, branches off about 6 to 8 centimeters proximal, and goes dorsally, so you won't have that. And you can get ultrasounds or MRIs to look at that Guillen's canal as well if you're worried about a compression from external mass effect, and then obviously get a nerve test as well. So moving on to radial nerve, you have your radial tunnel syndrome, your posterior neurosis nerve compression syndrome, and your Wartenberg syndrome. So let's see. Obviously, radial tunnel was described in 1956. It's pain without motor deficit, so it's just pain, no muscle issues. It's along the radial tunnel, worse with rotational activities, affects women more so. And let's move on to the sites of compression here. So multiple sites here. You have the proximal edge of the supinator muscle, the arcuated froza. You have these recurrent radial vessels called the leash of Henry, and then you have the proximal edge of the ECRB, the distal edge of the supinator, and you can have the fibrous bands, the radiocarpal joint between the brachialis and BR. So when you have this pain over the mobile wad, it's distal to the lateral epicondyle, and you can sometimes, you're trying to differentiate this between lateral epicondylitis because it seems almost similar, and there's no real pathognomonic test. Sometimes you can do a diagnostic injection distal to the lateral epicondyle and see if that helps. This little graph here kind of helps differentiate it. So, the lateral epicondylitis is more pain at the lateral epicondyle or just a little bit distal. And this is going to be a little more, the radial tunnel is going to be more in the mobile wad. And, resisted supination with the elbow flex is more painful, the radial tunnel, not necessarily with lateral epicondylitis. So then you also have posterior neurosis nerve compression syndrome, and you can get progressive weakness in the PIN, lack of MP joint extension, thumb extension, radial abduction. You can have a potential fracture that may be causing this, or you can have synovitis of the radiocapitular joint, and you get EMG findings which are normal earlier on. And this just kind of tells you the sites of compression here. They're similar to radial tunnel, except for it has more proximal and distal compression points, including the fibrous tissue anterior to the radiocapitular joint, and then also this ECRB edge as well. So how do you really differentiate radial tunnel from PIN compression syndrome? So when PIN compression causes progressive muscle weakness and subsequent loss of motor function distal to the site of compression, then it's called the PIN compression syndrome. When it just causes pain, cramping, and tenderness in the proximal forearm without the loss of motor function, then you want to call this radial tunnel. And then finally, Wartenberg syndrome. This is a superficial radial sensory nerve compression. The nerve is trapped as it's exiting between the brachioradialis and ECRL. So courses deep from between those two muscles and exits about 9 centimeters proximal to the radial styloid. And then you can get paresthesia of the dorsal aspect of the hand and wrist, plus or minus Finkelstein test. Sometimes your Finkelstein test is positive because the traction of the nerve with the maneuver. Tinel sinus really helps differentiate this from a de Quervain's tendonitis. And you can also exacerbate symptoms with wrist flexion and ulnar deviation. So take-home messages are compression neuropathies are common. History and physical exam are important, and you want to use your nerve test to help confirm your diagnosis that you made, help you get the severity of the diagnosis that you suspect, so you can counsel the patient and also review the test yourself. Okay, back to you, Harry.
Yeah, that was, put my video on here. That was very comprehensive, and it really highlighted um, many of the salient points. And we have some great questions, which we'll go over that were both from the chat and from other things. And kind of move inside now. It's getting dark. Still with some tie dye on though. But let's go back to this case because this is a really complex one. We have Peter Ree on the line with us as well, and I saw Jeff Lawton log on, so we have some good faculty. And go to the next slide here. I think we, yeah, Peter, would you think there's any issue with the? We'll just go right to the X-ray because we do some trauma. Do you think there's any major issue with the X-rays here? Is there any hardware that could be causing some median nerve, problems?
Yeah, Harry. The plate certainly looks like it's a little more volar than the volar rim. So, you always worry about at least flexor tendon irritation, and certainly you can, if it's pretty prominent or there's an associated dorsal tilt, you can get quite a bit of compression on the median nerve as well. So I think it's on the differential, certainly, that the plate could be causing some issues.
Yeah, but potentially this particular plate's a little bit thicker, I think, than some, and it gets close to that point. But I agree with you. Most of the patients present with index FDP or FPL or more tendon irritation than direct median nerve problems. Go ahead to the next slide there. Sana, why don't you comment on some of what you would look at as some of the salient points on the electrodiagnostics?
Hey, Harry.
Yeah.
Go ahead.
Harry,
Yeah, go ahead. Try.
do you have his pre-op, her pre-op X-rays, which
I do not, unfortunately. I really looked for him today. I spoke with the surgeon who took care of it, and he didn't think it was a dramatic. What I particularly asked, and I'm glad you alluded to it, was there a volar spike of the proximal fragment?
Cancellation?
Yes, correct.
Okay.
And he didn't think that it was significantly dramatic.
Okay.
But great point. And I think what you're alluding to is that if you have a lot of translation and then this volar spike comes up into the median nerve, this is not carpal tunnel syndrome. This is a median nerve contusion, right? Exactly. Or injury.
Yep.
Right. And we'll talk about what to do in these particular instances a little bit. We have plenty of time, but let's fast forward now. What do you had a couple of these on go over the EMG for us.
Yeah. So here you can see when you look at the motor nerve conduction study here, you can see increased latency. You see the norm value written right next to it. So you can see there's an increase here. And then if you look at the sensory portion of the nerve conduction, again, it's the norm, here's 3.5, you can see that's increased too. So and then if you look at the amplitude here, this is decreased. Again, the norm here for the motor portion is 5, and you can see that that's increased. And if you look, decreased. And if you look here again, it's also decreased as well. So it definitely tells you there's a median nerve injury going on.
How do you tell between the axonal loss and let's say the conduction block on these?
Yeah. So here, the thing is that when you look at the EMG here, this looks pretty normal. So I don't know why, do you know why they didn't put anything with I guess everything was just normal across.
Everything was normal there. So this is a really interesting thing. So, typically when when there's such a significant amplitude decrease, especially for the sensation there, when you see an amplitude decrease, that's the number of axons coming across. You just don't have enough players on the field, right? And it could be a little bit of the sampling, and it's really only going to be in the abductor pollicis brevis. So there could be a little bit of sampling error there. The latency is how good your players are, right? Are they tired? Did they not get enough Gatorade? And typically when there's decreased amplitude, there's a component of axonal loss, and you would see some findings on the electrodiagnostic study. But interesting when you talk to her, and I don't have a video, the dense sensation is what bothers her, right? Some pain's pretty reasonable. She does have some clumsiness in the thumb, but it's the dense sensation. So go ahead to the next slide. And this is a really good electromyographer because he then looked at each of the fingers for the median nerve, index, middle, ring. Obviously the radial side of the ring finger, and the thumb was interestingly somewhat okay, but 50%, 30%. So not complete knockout, but decreased to a certain extent. Motor response he actually thought was pretty normal in size, even though there was some decreased amplitude, but it did get above that 5. So I like looking at the numbers myself. Sometimes all you do is get a report, but I would encourage everybody to go ahead and look at the numbers. So go ahead, next slide then. So these are some tough questions, right? Jeff, are you still on the line?
I am.
What do you think about the first one? Why do I still have numbness?
Yeah, and that's a good question. You sort of alluded to it earlier. We don't know if this is a, so what we treat with a carpal tunnel release is compressive neuropathy. We don't know if this is nerve compression or nerve trauma. In other words, was the nerve stretched? We don't have the pre-op imaging, but you can imagine that if her distal radius fracture was dorsally displaced, that caused the median nerve to sort of take the long way around, and the nerve could have been traumatized at that point. You decompress the nerve, and we all do it, and that certainly improves the environment for the nerve, but it doesn't fix the nerve if the nerve's been directly traumatized or the nerve's had some stretch.
Yeah. I would like to poll our group to a certain extent, the number of carpal tunnel releases you do with distal radius fracture. Jeff, you're still on the line. Is it
probably 10 to 15%?
Okay.
There was a question that
one of the question.
Yeah.
Yeah, go ahead. Keep asking. What was one of the questions?
Well, no, I was just going to sort of paraphrase the question that they noticed a trend that they've been seeing a lot more carpal tunnel releases with their distal radius fractures. And I know that's some people's practice. Certainly I ask patients if they have symptoms, and certainly if the symptoms, are transient and go away, I don't necessarily do it. If their symptoms persist, I definitely decompress their carpal tunnel. But, probably on average, I don't know, 10, 15%-ish.
Yeah, so low number. I mean, one of the questions is that, did you have some carpal tunnel problems prior to your distal radius? Okay, that's an easy one. And then the second question, really, and we'll get this as we continue on, is when you have a nerve injury or a contusion, a nerve, does a decompression help? Right, that's what we're asking. Does a decompression help nerve regeneration? Peter, what percentage in your population?
Well, I think, sorry, too much light. I'm actually with Jeff. It's pretty rare that I do a carpal tunnel release for a true acute carpal tunnel syndrome and a distal radius fracture. And then usually, afterwards, they may have this, like you guys mentioned, the contusion from the massive displacement that usually with time improves. But like in this patient, a year out, I think you bring up some good points, because a true carpal tunnel syndrome is a demyelinating process. But here, if you have axonal loss too, it could be very well perineural scarring from just the injury itself, the surgery, which would, like Jeff said, a carpal tunnel release is maybe a small component to help with the regeneration. But, I think that you'd have to do a little more of a neurolysis more proximal to the carpal tunnel. But to answer your original question, I'd say it's pretty rare, Harry.
Okay, yeah, me too. So if you have someone who's pretty clear, right? So they've had some carpal tunnel problems before, they know what it's like. They have a distal radius fracture. They said, boy, it is worse, right? I got my fracture, and the fracture is reasonably reduced. Describe to us, is this a palm-only incision? Do you have to cross the wrist crease? Let's say you have a standard, I can't get my hands pointed all the way, but a standard FCR sort of approach. Do you add a separate incision? Walk us through a little bit your technique in both of these situations.
Yeah, I've kind of done them a couple different ways. I've done them, in the acute trauma setting, I've done them open. I've done through separate incisions. Sometimes I've combined them with an extensile approach. Sometimes I try to avoid doing that too much because I don't want to injure the palmar cutaneous nerve. I've done them a little bit delayed, sometimes even with an endoscopic or I have the distal radius. So I've had good results with all of those. So I think it just kind of depends what you feel comfortable doing in the patient that you have. If you have a big swollen hand that's full of hematoma, I'm not going to do that endoscopically, but it just depends on the patient as well.
Yeah, okay.
Hey,
I
Eric?
typically make it. Yeah, go ahead, Jai.
I think it's important for us to try and make a distinction between acute carpal tunnel and nerve contusion.
Mm-hmm.
And one of the ways to think about it, and it's by no means foolproof, but if you have unrelenting progression of tingling and numbness despite an adequate reduction is more likely to indicate, progression being the keyword, is more likely to indicate increased carpal tunnel pressure. But if you have static dysesthesias, which are unchanged despite adequacy of reduction, they may actually indicate more of a contusion rather than compressive neuropathy. So that's number one. And number two is, I'm a big believer, and I'm going to go out on a limb here. I'm a big believer in releasing carpal tunnel for people over the age of 60 or diabetics or high energy injuries, simply because I think that the change in the volume of the carpal tunnel helps with digital flexor excursion. And I find very few people who I do that actually have digital stiffness. So something to think about.
Yeah, very interesting. I think what Chai alludes to, and I'm going to say it again because I think it's very important. When someone has an acute injury and the median nerve problems occur at the time of the injury, boom, it's static. It doesn't get worse, doesn't get better. But it's bad. That's different. That's a nerve injury. Versus, and this is a little bit of serial exam in good patients, is that, boy, I was pretty good. I had it really bad. It got a little better after my reduction, and now it's getting a little bit worse. And they have this numbness. And that's what I think, some increased pressure or swelling within the carpal tunnel itself. And I'll just, my personal experience is I use a palm incision, but I'm ensure that the forearm fascia is adequately released either through that or through the, I use a sort of, let's say, a radial incision for the procedure to get both of those done. I wanted to, we'll wrap up this one, and then we have a couple other good questions coming up. But in this particular instance of, let's say now, it's not recurrent, but it just sort of has gotten worse, has gotten better to a certain extent. What can we tell her if she elects to have a revision release, and obviously in the palm and across the wrist to a certain extent? We tell her what parts are going to get better. Sanu, why don't you tackle that one?
Yeah, one thing I want to check on her. So, is there any evidence of any proximal compression, Harry, on her at all, like proximal median nerve or anything coming?
No, not that I can tell. She does have a Tinal sign just proximal to the wrist.
Okay.
Okay. So not so much in the carpal tunnel. The scar is pretty supple, but it is just proximal to the wrist. So that maybe that's a site of secondary compression.
Yeah.
Right.
No.
What do you think's gonna get better in this particular instance?
Well, I mean, she's a year out. I mean, and I think if she had an injury there, and you would expect it to have reached its point. We're not talking about an injury high up in the elbow that has to reach the hand here, to travel. So I think that it's hard to tell her definitively that she's going to get better, but I do think it's reasonable to try a carpal tunnel release and do a revision one and see if you can make that better. And I would tell her that, I think this is your best shot. I can't tell you if this is going to make you better. So I don't think you really can, because we don't know. I think once you go in there, you may be able to look at that nerve and get a better idea. You can see what physically is going on with that nerve, whether it looks like it's been compressed or looks like there's actually direct nerve damage from the initial distal radius fracture displacement.
Mm-hmm. Jeff, how much of a neurolysis in these particular instances are you doing? Do you pull off the scar off the epineurium, or put something around it, or fat pad, or in other words, in a regular carpal tunnel release, I think we just kind of do the release and say, okay, what about in these tough situations?
Yeah, agreed. And what Sanu mentioned, basically extending or sort of doing a more traditional carpal tunnel release, going above the wrist crease, that certainly may help. I think I'd be hard pressed, though, to just do that. I think I would want to do something to make a little bit of an environmental improvement, as you were saying. And, Dean Saturianos champions a vein wrap. I actually like the Steichen and Eidler hypothenar fat flap. I think you mentioned Paul Binhammer. He gave a real nice talk and video demonstration of that. So it's the difference between doing a 20-minute operation, meaning doing a more thorough or more extensive sort of carpal tunnel release, versus doing a 45 or 50-minute operation. But, I think if I can do something to improve the environment for the nerve, you've sort of done everything, because as much as you don't want to go in a second time, you don't want to go in a third time. You know, but then academically, you never know, was it your extended carpal tunnel release that helped her, or was it the, you know, the pedicled fat flap? But
Yeah.
I would tend to do that.
Great, thank you. Becky, what if they've had a distal radius fracture and they've had a carpal tunnel release, does the rehabilitation change, or what things do you have to add for the, let's say, this nerve injury, you know, to either promote regeneration or prevent other problems?
So the first thing I'm going to make sure to do is a very comprehensive sensory evaluation. And so I'm looking at either Sims-Weinstein or a 2-point discrimination and making sure I do that thoroughly and consistently so I can help track and monitor with objective data if we're seeing any actual worsening of symptoms. In my opinion, a lot of patients confuse pain with numbness or kind of superimpose the two on each other. And so wanting to make sure also to have good pain measurements, but having that objective data stay separate. I might, in these kind of cases, if the patient is extremely painful and with this level of numbness and tingling or weakness, you know, thinking about how to keep them comfortable at night is something that I might add that's different than with a typical distal radius fracture. If you've given us good fixation for us to move the wrist and get them going, typically with a distal radius fracture, we can get things moving pretty quickly. When you add this layer, I think this is where I take a step back and say, you know, let's really modulate and make sure the patient is comfortable and that we don't exacerbate their pain by trying to move therapy too quickly. I think pain is something we need to respect, and the numbness and tingling is something that I really want to measure and make sure I understand what's going on.
Yes. Yeah. Okay. Thank you very much. And what are there any, Becky, any things you can do to help sort of sensory re-education? Do you do different, let's say, fluidal therapy or different types of materials or those sort of things?
So it's a really good question. And actually the literature has come a long way in the past 5 to 10 years about sensory re-education. In old sensory re-education, we really thought about using our tuning forks as a way to understand when to start having the patient work towards sensory re-ed. And so I would say that honestly, we were just sitting around and waiting. And so in the past 10, probably even 20 years, you've seen therapists be really interested in the brain and the hand and the cortical representation of the hand. And so you see therapists now using Sims-Weinstein as a way to begin understanding timing for sensory re-education, thinking about sensory imagery, thinking about cortical visuotactile, as well as cortical audiotactile, like I was saying before, using those other senses to help compensate for the loss of sensation. And then as you see Sims-Weinstein improving, then advancing to the next phase of sensory re-education. Desensitization, I think, is also what you're speaking to, which is the idea that we can use different mediums. And so this is anything from a bucket full of cotton balls to more like popcorn or rice. Warm rice is an interesting medium to use as long as you don't have edema. And then you can use really kind of gross things like gravel and things that are very uncomfortable. I think vibration is another great way to do sensory re-education, and people in their homes have things that vibrate, like their vacuum cleaner and their blow dryer and their toothbrushes. And so then you've got things around the house that they can kind of work on trying to hold or trying to work with to increase their ability to use their hand. And so there's a lot of good opportunities for people in their home to be working on these things with different textures that are all around them.
Yeah. You know, one of the things that I see and I really reinforce is that if they've had the median nerve problem and this is that digital motions really can be harder and really focus on digital motion. Go ahead. Yep. We got 5 minutes.
It's funny that, and interesting that Becky mentioned vibration, because about 30 years ago, we used to use vibrometry as a test for diagnosis of carpal tunnel syndrome. It was called the Jetzer Index. And it never quite caught on, but it was a valuable tool in those days for diagnosing, using tuning forks of varying frequencies to diagnose carpal tunnel syndrome. Just a, you know,
different. Yeah, could they feel this part or couldn't they feel the best part? Actually, vibration testing is some of the most sensitive testing available, and some people are tracking, as you say, Becky, after let's say a peripheral nerve injury as the first signs of regeneration. So yeah, I mean, I think these folks need a lot. Let's say I don't say a lot of help, but they really need a lot of attention and structure at home. So, you know, here's the last two things. What would help in this particular individual? Because there's one other question I want to ask the panel. But I often tell them, listen, if you're having pain, the pain can most likely reliably get better. The sensation is going to be tricky because this has been present for a good year. As Chai alluded to, there's probably a component of compressive neuropathy as well as some sort of nerve injury. And some of that we can recover. If it's a compressive problem, you can recover it. If it's an internal architectural nerve problem, you know, that's only going to partially get better. So I think the sensation is plus minus, but pain and any sort of potential stiffness in the fingers, I think gets better. Guys, any other comments? I don't know any comments, because there's one other question that came up that I think we should go over.
No, I just had a quick question. So does from the panel, anybody use any other means to augment these irritated nerves? Any kinds of products or wraps or anything like that, in addition or instead of to the hypothenar fat flap?
Yeah, so I'll tackle that one. So the hypothenar flap that Jeff alluded to is excellent over the area, let's say, that it reaches. Okay, so it's very good in the palm. You get a little bit proximal, but if you have this kinking that occurs, or do we think that it's adherent somewhere else, that it doesn't necessarily reach to that area. And the gold standard, the creme de la creme, is the vein wrap. The nerve loves intima. Okay, so the intima wrapped around is the best, but that certainly is some morbidity in harvesting the vein, and the procedure can take a while. And I think what you're alluding to is, you know, does a submucosal wrap help? Is it collagen? Is it amnion? And at present, none have been, let's say, superior one versus the other, but they do provide a pad. Okay, so it's like a pad around your elbow or a pad around the nerve. They provide a bit of a barrier. And one of two things is going to happen. Either the wrap is going to stick to the nerve, and that then will move as a unit separate from the, let's say, the scar reforming, or the wrap will kind of stick to the scar and the nerve will go inside of the wrap. All right, and so each one of these things is a little bit different. I personally think things that have polarity, obviously the vein, the nerve goes inside of the vein, and then the outside, which is the adventitious, sticks to the scar tissue, or has adherence to the scar tissue. Some, like collagen, will have adherence on the outside, but also to the nerve. Submucosal has some polarity, and the idea is that it will glide in between. Jeff just asked a question about Gore-Tex. Gore-Tex is unbelievably slippery, and the original wraps was by Gore and Lundberg, and they did use Gore-Tex. Oddly enough, the very first in his journal Hand Surgery, and had great commentary. And for years in the 90s, people put Gore-Tex around the nerve. What we found is that it can cause some secondary reaction thereafter. It can be extruded into the wound, and we sort of got away from that. But interestingly enough, in nerve repair and in recurrent compressive, they use them in Sweden a fair amount because they were relatively cheap. So that's a great point, and I think you're going to see these things because, you know, it's a lot easier than harvesting the vein. So I guess long-winded answer. Stay tuned. But I do try them, and I'm sure some of the people on the panel do as well. Especially in people that are very thin, don't have a lot of fat. Their scar was very adherent in the first go around. I have a question. If someone has, let's say, cubital tunnel and carpal tunnel, and this came up a little bit, and you know, we all have our ways of distinguishing one versus the other. Jeff, why don't you tackle it? Do you try to separate the procedures, and or you do them together, and then we're going to go to Becky, and how do you rehab one versus both? So first, just separate or together?
No, if they have both, I take care of both for them at the same time.
Okay.
And I don't think the rehab of one gets in the way of the other. I don't think, you know, I mean, sometimes some things we do, the recovery from one procedure where you want to immobilize gets in the way of something where you want to mobilize. I think the recoveries of both are sort of coincident. And obviously you have to do different components for each, but I don't think one gets in the way of the other. So for the patient's ease, I take care of both at the same time if I think they're both going on. Good.
Becky, I think Jeff alluded to, he thinks the rehab's about, you know, pretty similar, no big issues there.
Yeah, and it's going to be easier just to get it all done and have the patient recover, and it's just an easier process for them, I think, as well. So I agree completely.
Yeah, I'll play a little bit of the difference. I have a little different population sometimes, and I'll sometimes do the carpal tunnel release first. Maybe I have a hard time if it's a tweener, right? So if they have good diagnostics and there's a conduction velocity, and say, boy, my small fingers down my whole arm gets dead. Yeah, both of them at the same time. But some of these people say, oh, my kind of my whole hand's bad, but it's hard to tell. Sometimes I'll just do the carpal tunnel release and see what happens on those sort of tweener cases, which the electrodiagnostics are okay. Last question: does anybody operate on compressive neuropathies with normal EMG? Chai, why don't you take that on? You're a little avant-garde. I set you up for that one, huh?
Yeah, I love you, Harry.
Yeah.
So it really depends. If you had asked me this question 20 years ago, the simple answer would have been no. But that's when we did not have the added benefit of ultrasound as an augmentative tool in diagnosis making. So for me, if I have patients who have classic symptoms, and I'm concerned that they have carpal tunnel syndrome, but the electrical studies are negative, I will get an ultrasound. And in my institution, we rely on two criteria. And the first one is the volume of the median nerve at the distal forearm in excess of 11 millimeters squared, which I think is not as good as comparing the volume of the median nerve in the distal forearm to the carpal tunnel, and the ratio being more than 1.5 as compared to the opposite side. If the ratio is more than 1.5, it is very diagnostic. Now, if you look at some of the data, and I think John Fowler has been very, very prominent in promoting the use of ultrasound, and his data is quite encouraging and convincing. So I use ultrasound as an augmentative tool. And I do the same thing for the ulnar nerve at the cubital tunnel. If I cannot do that, if I can't get an ultrasound for whatever reason, then I will space my electrical studies 6 months apart and look for an interval change. But I've gone away from operating on people for electrical studies negative symptoms if I cannot prove my diagnosis objectively in any way, shape, or form. To me, it's a little bit risky. So
okay, yeah, great. Anybody else? Anything else that you can help differentiate in these normal situations?
So for carpal tunnel specifically, if their history and their exam is very consistent, I'll give them a steroid injection. And that's sort of a test. It may help them transiently, but at least that sort of clues me in that it is carpal tunnel. They say up to 10% of people with carpal tunnel syndrome have normal EMGs. So, again, if everything fits and they get a good, albeit temporary response to an injection, then I'm happy to do a carpal tunnel release.
Okay, yeah, I think I use that quite effectively. And sometimes for the ulnar nerve, I'll have them, as Chai says, repeat the nerve test, and you could do it after elbow flexion, for instance. That has been somewhat or a dynamic test with the ultrasound, right?
Something?
Pardon me. Yeah.
There was a paper in which I think Peter Stern was the last author, and I think it was published about 15 years ago, where they looked at patterns of numbness in patients with carpal tunnel syndrome, and they came up with 5 patterns of numbness. And one of the patterns being classic 3.5 radial digit symptoms. And then they had 4 other patterns. And I think that's one of the most underappreciated papers, because patients will come to you with all kinds of bizarre symptoms, especially diabetics. And I think that paper really, really sheds light on patients' symptoms without actually being anatomic. So if I could ever encourage people to read a paper, it would be that one. It was Peter Stern was the last author.
Yeah, and also you'll have some patients that as Jeff alluded to, will have these abnormal symptoms. You do a corticosteroid with lidocaine injection, and they'll say my small finger got better after my carpal tunnel injection.
Yes, I don't use steroid injections, but that's why I rely on that study. So
yeah, okay. There was a couple questions. Go ahead. Yep.
One question here for Becky, which I think might be interesting.
That's what I was just going to go over that. How to manage scar. Right. That was one of the.
Yeah, and actually I added it into the question and answer. This is what eludes all of us. And I think it's both external scar and internal scar. And certainly later on in these series, we'll talk about flexor tendons and extensor tendons. And, when we're thinking about external scar after a carpal tunnel release, the first issue we have as therapists is there isn't a really great objective way to measure scar or to measure change in scar. It's all very subjective and sensory based by our sensation. And so the second piece is different patients respond differently to scar techniques. And so one of our participants, Amy, was saying, you know, this idea of paper tape versus, you know, using silicone, using all these products. In my experience, what I have found is that if you start scar massage early and the patient feels very comfortable to really start touching, working on, and really start moving that scar, the end point typically will be good. Now, you have some patients that are going to scar worse than others, and you're going to have those issues. I think there's many tools in our arsenal, oils, different creams, you've got tape, you've got silicone, and I think you just have to try to find the thing that works best for your patient. I think there's lots of good options out there.
Thank you very much. We'll go just a couple more minutes in this, is because this is, you know, this sort of nerve stuff is pretty fascinating. I'm going to take on one last little topic. Chuck, I saw you were on the line. Can I ask you a quick question? Are you able to get to your phone or a computer? If he's not, I'm going to go to Peter.
I'm here. Hey.
All right. Hey, so Sanu showed this lovely video of the ulnar nerve. And we all agree that if it subluxates, but what about the one that perches up to the epicondyle? I gave you a tough question. I'm sorry, but you know, it gets to the edge, but it kind of, you know, it's
yeah.
I mean, so
that's a great.
Yeah. So we all see this.
So there are a couple of factors that I consider. So one is how tender the nerve is, how sensitive the nerve is, how much padding the patient has around that area. And then the other is the age of the patient and whether they have comorbidities. So for example, that one's easier for me. And if it's an older patient, especially a diabetic patient in their 60s, I don't transpose the nerve anymore unless the nerve dislocates. I do the little Satyrianos bumper with the sling from the triceps. So it doesn't compress the nerve. It allows it to ride up, but not over. And I like that. I had the unfortunate experience of having one of my fellows back in the day operate on a patient at the VA who was diabetic with ulnar neuropathy that was sensory only. And he did an ulnar nerve transposition and killed a nerve. So I went back in, I explored it later, and he had done a perfect transposition, and I think the nerve was just devascularized.
Yeah.
So in that patient population, I try not to.
That's an interesting point. I often will be in the sedentary population that's sitting on their arm all day long, right, on their wheelchair or in their chair. I might transpose those because there's still going to be some external compression onto the nerve, right? That's those groups sometimes coincide. The nerve does revascularize, but you know, I guess in your instance, you think that it just takes too much of a hit during the procedure, then, huh?
Yeah, and I do if I transpose the nerve. You guys talked about it, but the inferior ulnar collateral artery branch of the ulnar nerve, I look for that. I protect it. When I transpose it, there's a little foramen that it goes through the intramuscular septum. Release that, and so I haven't had that experience myself operating, but it's anecdotal, but it never recovered. I followed that guy for over a year, and he had complete ulnar nerve palsy from that transposition.
Got it.
I think Chuck makes a very valuable point there. I think there's a couple case reports of that. And about 30 years ago, Bill Kleinman made this really, really important point of this, that when you release an ulnar nerve and transpose it like Chuck was talking about, it's so critical to maintain that ladder-like vascularity of the ulnar nerve along with the nerve when you transpose it and not skeletonize it. Because when you skeletonize it, that's when you run the risk of devascularizing it, like Chuck said.
Yeah. He also showed that the nerve does revascularize, right? So sometimes you can't bring that pedicle up with it. The other important part you allude to those is that the collateral branch by the intramuscular septum, if you can preserve that at all costs, that at least helps feed the nerve later. Peter or Sanu, any other comments on that perched ulnar nerve? Peter, go first.
Yeah, this is Peter. I completely agree with Chuck that it's based on the patient, and a lot of times, I think you're going in knowing that if it's gonna perch, what you're gonna do, and by that I mean how severe the ulnar nerve or compressive neuropathy seems to be. you know, those times that you've been doing just even an in situ and you just barely touch the nerve and you see the FCU flicker, you know, I think patients like that, if they end up perching and then subluxating, I think those patients will continue to have some of these symptoms of persistent tingling or radiation down the hand. And so if the patient is someone where, like Chuck said, I'm afraid that they're going to have some complications down the road, they're diabetic, elderly, then perhaps I won't. But to answer your question, I base it on the patient, but then really on how bad their symptoms are. Because I do think that a transposition submuscular is probably the gold standard in the revision setting, but also to effectively decompress all the potential sites of compression if done correctly.
Got it. Sanu, any last comments on this one? And then I think we'll wrap it up.
Yeah, no, I agree with Peter and Chuck about that. And if you ask my partner Amy Moore, I mean, she'll say, I asked her this question because we had an interesting case where I was doing this, and she would transpose them for all the reasons that was said, just because what happens later on to the nerve once it subluxates, because even with that sling, it may not hold through. And if you see them later on, I mean, she's seen them. That being said, when I do mine, in those certain cases, I will use that fascial flap off the medial epicondyle and suture to the fascia just posterior to my skin incision, deep that fat, and sort of use that as a dam to sort of prevent it from doing that in those rare cases. But it has to be, again, the right case for that.
Yeah, these are important parts. And I think that if we can go to the next slide, we have some other things to wrap up a little bit. But nerve surgery, it requires some experience. You've heard about how everybody looks at the caliber of the nerve, the color, the vascularity. Peter alluded to the sensitivity of the nerve during surgery. How does it react to touching, electrical stimulation, all these sort of things. Each one of these things are important, so that you need in your toolbox, in your armamentarium, lots of different things. As you can tell by my voice, I get excited about this. And on the back end, I can't reiterate enough the rehabilitation, preventing CRPS, preventing the neuritis later on, the adjunctive use of anti-inflammatory steroids, orally, all these things to prevent the later effects that can occur after operating on a nerve, including all the therapy modalities we talked about, are very important. So go ahead, so if you can, go to the next slide. We ran a little bit over, but I think it's a big topic. Chai, we have coming up I'll go over to the chairman here. We have a couple other wonderful series, which probably delve a little more into the fracture side. But each one of these, as Sanu said today, has a potential for nerve involvement. So even though we finished with nerve today, it can come up throughout the rest of the talks. Chai, any last comments, or here's the schedule for the rest?
I just must commend you guys for doing such a fantastic job. Sonu and you for covering what is, this is a huge topic. We could have an hour or more of each of these things, but you've done a remarkable job, and thank you. I think that's wonderful. By the number of questions we were asked, it clearly shows that you excited a lot of interest. So thanks a lot. Well done.
Okay. See everybody next week.